It's now recording, but I just want to say thank you everyone for joining. My name is Caitlin Miller. I work with the Iowa Heart Foundation. I am their Heart Corps service member at the moment. The Iowa Heart Foundation is a nonprofit organization that started over 30 years ago by the physicians at the Iowa Heart Center. And as an organization, we focus on heart health education and heart disease prevention across Iowa. Um, we will have the chat open for anyone to ask questions during the presentation, and then at the end we will come together as a Q&A, and Terri will be able to answer any questions that you have. But I'm happy to introduce Terri Hamm. She's the stroke team coordinator at the Mercy Medical Center, and she will be discussing stroke awareness. So I will now hand it over to her.
All right, can everybody hear me okay? Awesome, okay. So today I'm going to talk to you about acute stroke care. This is Stroke Awareness Month, and I very much appreciate the invitation to have this conversation with all of you. So we're going to talk about thrombolysis, thrombectomy, and beyond. That is, in essence, all the things that we do acutely to take care of stroke. But there's more to the picture than that, and we'll talk about it kind of going on from there. So next slide.
Okay, sit tight. I'm going to try to see if I can't get this to move forward. There we go.
Okay, so the objectives for this discussion are that your participants will be able to define appropriate thrombectomy cases via vascular distribution. Participants will be able to define appropriate windows for thrombolysis treatment. Participants will be able to discuss local standards for identification of appropriate thrombectomy candidates. Participants will identify which scans assist in determining eligibility for thrombectomy, and participants will develop knowledge of acute and immediate post-acute care. And I think it's important that you understand the reason we talk about this is if you understand what we're doing and why we're doing it, it also makes you a little more keenly aware of what a stroke patient looks like and why it's so very, very important that you take immediate action. Time is brain, and you'll hear me say that frequently. Next slide. So we're going to talk about the signs and symptoms of acute ischemic stroke, and you'll see me kind of document that as AIS, but that's acute ischemic stroke. And I like to think about these as the suddens. You'll hear things like fast and be fast. I think the suddens for me is really important because strokes don't just kind of come on gradually. They are a sudden neurological experience. And so it's very important that you understand the difference between something that kind of comes and goes, or it's been coming on for a few weeks, versus something that's very acute and sudden. So what we're thinking about are things like sudden weakness, numbness, tingling on one side of your body, sudden trouble speaking or understanding speech, sudden dizziness, loss of balance or coordination, sudden changes to vision or visual fields, a sudden severe headache with no other known cause, and it's time to call 911. Next slide, please. So let's talk about time. This is huge. And when we get patients in, oftentimes from outlying emergency medical systems, we get them from outlying hospitals. A lot of times families or witnesses will call us and say, guess what? It's 6 o'clock in the morning. They were normal. Or they'll say this is when this started. But what we see is that oftentimes what people are identifying as last known well is actually the time that they recognize there were symptoms. So what time was the patient last seen at their normal baseline? And that means, sometimes we have to ask that question a few different times in a few different ways to get to the bottom line. Time, was it a witnessed event? Did you see that patient normal and have them have an acute situation occur in front of you? Time, 911. Call EMS. Do not drive to the hospital. Do not bring your loved one into the hospital. Make sure you're calling 911. Now, the caveat to that, and I will say this, we live in a very rural state, and EMS provision is not always something you can rely on. If you know that you live in an area where there is a volunteer EMS system, where there might be one EMS system in a very large county, and you can't rely on them getting to you quickly, that might be the exception to the rule of take your loved one to the hospital, especially if you live very near to a hospital, a rural hospital, county hospital. That might be the exception to the rule. And we always talk about, in every instance, there can be exceptions to these rules. When we think about time, we think about the time from the time that patient arrives at our door until we get that CT. So if you guys are, and you are, your people are all thinking heart a lot of the time, right? You want to get that door to EKG, right? I want you to think about CT scans as my EKG for the brain. That essential scan is like your EKG. We have to have it so we can start to identify what is or isn't wrong with the patient. Then I also think about time from CT scan to interpretation. We need to get that read done quickly so that we can then act upon it. And then time from interpretation of that CT scan to a treatment decision. Time is brain. And as I said, you're going to hear me say it again and again and again because it is. Next slide, please. So let's talk about thrombolysis. So this is a little bit about the journey from alteplase to tenecteplase. Many of you may be very familiar with the term TPA. And some of you, a lot of you might even be familiar or maybe even more familiar with TNK or tenecteplase. Ever since 1996, alteplase or TPA was the gold standard for acute stroke treatment. The FDA approval for the TPA was really within 3 hours, but science does much better, and you guys know that as well as I do, right? Science is always way, way ahead of the FDA doing anything. So, years ago, we had a study called ECAS-2, and it showed statistically significant improvement in outcomes with the window widened to 4.5 hours. Imaging has improved over time, and that's opened the window even further. So we now potentially can treat a stroke out to 9 hours from last known well with thrombolysis, which is, that's a big change. That's a huge change. And a lot of people get really uncomfortable with it because they're like, well, but that seems like so long. But remember, we have imaging that helps us to better understand what that infarcted tissue may look like, and it makes it much more clinically safe to do so. And I kind of joke around with some of our neurologists even get a little twitchy about this sometimes, certainly some of my ED docs. And what I remind them of is, if I had $1 for every patient who swore up, down, and sideways that their last known well was at 10 o'clock this morning, and we are like, okay, well, we're going to go ahead and treat. And then, 6 hours later, a loved one comes in and says, well, they weren't right last night when they went to bed. And it's like, oy, but they didn't bleed. There was no disaster. There was no horrifying situation. So we really, in truth, have been treating outside of actual windows for a lot of years. And when I remind people of that, they kind of calm down. They're like, you kind of maybe have a point. I'm like, I sure do. This is a lot safer because we can see the imaging and it tells us what we need to know. So the other big thing is that we are able to utilize alteplase in pediatric stroke. We do follow scientific protocols. That's a question I get a lot. What about pediatrics? Do they actually have strokes? Yes, they do. And as we get through this, you'll see that I put in a case study about that. Extend IA and Timeless are looking at TNK and have looked at TNK versus TPA. Many hospitals have changed their practice and now use TNK. MercyOne here in Des Moines, was the first hospital in the state of Iowa to make that transition. And we've done it about 3 years ago. I think when we first got the data, we try to be evidence-based. The evidence was very supportive of transitioning to tenecteplase. It has multiple advantages. It's the ease of dosing is much, much easier. It's one IV push. There's no drip. And if any of you guys have ever had to take care of a patient that's coming in from an outlying hospital with those drips, what a nightmare that is. Because they never have the right pumps, and then you lose all this drug in the tubing if you try to change it. And so it just really, it was never ideal when we had to do that. Now the patient can be treated, and the transport is so much easier and so much better for the patient. Next slide, please. So patients with disabling symptoms should be considered for thrombolytic therapy if they arrive within a window of opportunity for treatment and have no contraindications. For some reason, I think this is still like an old wives' tale that's hanging around from 1996, but age is not a contraindication. We have treated patients as old as 104. And I love to tell the story about this particular lady, and I'm going to take the time to do that. She came in, she had left-sided weakness and some dysarthria, but it was definitely going to be disabling. She, at 104, was living at home alone, or at home independently, not alone. Her boys lived with her. And when we were debating, whether or not the risk and benefit, we were kind of talking through it with her. And she looked at me and said, if I can't go back home, my boys are going to destroy my garden. I had no choice. I thought I was going to have to resuscitate my neurologist, but I'm like, what? If she's 104, what harm can we do? We know what's going to happen if we don't treat her. And I will tell you, she went home and she did well for another almost 9 months. And then she just passed naturally. Warfarin is a contraindication. We have a lot of patients on warfarin, but it's only a contraindication if the INR is greater than 1.7. Oftentimes we see patients that for whatever reason, their INRs are not appropriate, and then they're going ahead and stroking. We can treat those patients for an INR of 1.7 or less. Factor 10A inhibitors taken within 24 hours are a contraindication. So those patients that are on Pradaxa, Eliquis, Xarelto, those patients are not going to get thrombolysis. If they have a prior history of hemorrhagic stroke, period, it is a contraindication. Somebody asked me yesterday, we had that situation present itself, and they're like, yeah, but it was 10 years ago. I'm like, I don't care. It's still a contraindication. We know that brain will bleed. We are not going to take that chance. Any recent surgery that is in a non-compressible site. So we've actually given tenecteplase to people with recent BK amps, that type of thing, where we could compress the site and it was safe to do so. But that's always in consultation with the surgeon. If the patient's had an acute ischemic stroke within 3 months, that is a contraindication. That brain is still fragile and likely to bleed if we give the patient thrombolysis during that time. Always thinking about balance between risk and benefit. And the thing that I would like to really point out is that the people who should be making the decision about a disabling situation for the patient are the patient and family. Even if they have I've seen this actually happen. We had a pianist who made their living playing piano, and they had distal hand weakness. That was a disabling stroke for that patient, and we went ahead and treated. So it's really important to remember to include your patient and family. What is disabling for the patient is disabling. Next slide, please. So let's talk about thrombectomy. A little bit of background and history. In the 1990s, all the way to about 2006, intraarterial TPA was utilized for acute ischemic stroke with some varying degrees of success. There wasn't really good data, and we did primarily use it for large strokes that could not receive IV TPA at the time. Then in 2006, interventional management of the Intervention Management of Stroke trial, IMS3, launched via the National Institutes of Neurologic Disorders and Stroke. And we were actually a site for that trial. And I will tell you that I gritched and complained and argued and fought with all of our docs. I'm like, this trial design is terrible. I don't care what the outcome is. The trial design is terrible. And of course, it was a negative trial. So then everybody was like, oh, well, the evidence doesn't support. And I'm like, the evidence would support it just fine if it was designed correctly. Apparently, somebody thought I was onto something, because then there was multiple other trials done that were appropriately designed. And guess what? When they really looked at those other trials, they were like, yeah, you know what? Okay. So next slide. And as I said, I wasn't the only one that had concerns regarding trial design. It just, you guys, whatever you do, when you look at evidence, make sure that you're making that the trial design in the trial makes sense. If it doesn't pass the smell test, really look at it with a critical eye. I think that's really important. And that is part of the scientific process, right? Sometimes negative trials aren't necessarily negative. They're telling us we didn't look at something correctly, and we have to look again. So it's important. So because everybody in the stroke world essentially said, listen, this doesn't make sense. It doesn't make sense. They called for additional trials. 2015, SWIFT Prime, Extend IA, and Escape all completed with overwhelmingly positive results. Amazing what that happened. What happens when you do it right. Thrombectomy for large vessel occlusion was quickly added to our arsenal for acute stroke treatment, and it has changed the world. For the patients that require this treatment, I can't even begin to tell you. We did 3 thrombectomies yesterday with 3 massively successful outcomes. I mean, it's changing people's lives. It is now considered the standard of care. Go ahead and switch, please. However, it's nothing's easy, right? Despite the success of thrombectomy, the availability remains limited. It really does require a specific expertise and performance of the procedure, trained staff in your ED, your CT, radiology, your IR. You have to have protocols and training, proper identification of candidates, and equipment acquisition. There's so much that went into this. I felt very strongly that we participate in this process. And so we start, as soon as we had the data, we started our campaign here at MercyOne to become a thrombectomy capable center. And the running joke is that I must have sold my firstborn, because I managed to get capital expenses and the whole bit. But it was just so important, because before we came on board, the University of Iowa was the only hospital in the entire state that had the capacity to do this. So you can imagine their outcomes were not great, because people were flying them 3 and 4 hours across the state just to get them to the University of Iowa. And by the time they got there, their ischemia had gotten so terrible that they were not going to have great outcomes. And so it was funny, because people would always ask me, well, isn't there a big rivalry with you guys in the U? And I'm like, oh, the U is thrilled that we're doing this, because they're getting the appropriate patients in the appropriate time frame. We're getting more of the appropriate patients in the appropriate time frame. And both of our outcomes, raised the bar. It was so much better. And so it was very important that we continue to do that. Next slide. I can go on to the next one, because we really did. In 2017, we did the very first thrombectomy here. And it was on a 92-year-old female who also returned to perfectly normal following the procedure and was discharged back to independent living. And you did the right thing, right? And it was worth selling my firstborn. But who qualifies for this? I'm sorry, next slide. Large vessel occlusions. What are large vessels? So these include the internal carotid arteries, the basilar artery, the M1, M2 branches of the middle cerebral arteries. And they also do, to a lesser extent, will look at the anterior communicating artery and to the picas in the posterior circulation. We really want those patients to be within 24 hours of last known well. That's what the evidence supports. But there's a caveat to that. It depends on the significance of the deficit, the degree of infarct versus penumbra. So time may be altered a little bit based on the imaging that we get. We typically want to see an NIH stroke scale score of 6 or greater. However, there are specific deficits that will lead us to look for that large vessel occlusion. In particular, speech. That's going to be devastating for anybody if you can't communicate, right? Next slide. So I'm going to give you some case presentations because I think this is the best way to understand some of this. Our very first case presentation is a 17-year-old Latina female who was out shopping with friends. She suddenly developed some right-sided weakness, a speech defect, and a gaze preference. She was taken to a local hospital and identified as a possible stroke in progress. Transferred to us, to our pediatric emergency department, where a stroke alert was called. The stroke team responded to the alert. A CT angiogram, and CT perfusion were completed, and an MRI with diffusion-weighted imaging was done. This was early on. This is still a pediatric patient. And so our pediatric neurologist wanted us just to confirm with MRI that there was indeed some ischemia going on. This is a 17-year-old without any risk factors identifiable. So the results of the imaging revealed that M1 occlusion that we talked about in the left middle cerebral artery, and that tracks, right? Left side of the brain controls right side of the body. So it tracks that she would have right-sided weakness, speech defect, and all of that. The decision was made to treat this patient with Activase followed by thrombectomy. And the outcome for this patient was that she returned to normal following the procedure. So, in fact, she returned to normal on the table, and she said some interesting words, and then immediately said, "Please don't tell my mother I said that." And so we all we got a big chuckle, and we said, "Oh, it's like the confessional. We'll never tell your mother what you said in here." So, again, this is just such an evidence for the fact that this can happen to anyone at any time, and we can't always identify why. Next slide, please. Our second case presentation is a 40-year-old Caucasian male with one-day history of dizziness, headache, visual field changes, and was seen at an outlying facility 24 hours prior to admission here. He was evaluated and discharged. He presented back to the facility with altered mental status, rapidly decreasing level of consciousness. A CTA was completed at the outlying facility at that point, and a basilar artery occlusion was identified. And for those of you that aren't super familiar with your neuroanatomy, the basilar artery feeds your brainstem. And I personally am very fond of my brainstem. I like to eat and breathe and swallow and walk upright and have a blood pressure and heart rate and all those cool things. And the brainstem really does keep you alive. So this was a very critical situation. Now, remember what we talked about, that 24-hour window? All the windows go out the door when we're talking about basilar artery occlusions. We will always try, because the alternative is likely death. For a 40-year-old, that's just unacceptable. So we had the patient sent here very rapidly. And like I said, we know that likely outside the 24 hours doesn't matter. We decided that we were going to try to get that clot no matter what. We had a successful thrombectomy. And unfortunately, upon return to the ICU, the patient proceeded to herniate in his brainstem. And at that point, organ donation was pursued. Even though we can't win all of them, this was vitally important, because this man had a family. And this family could at least take some solace in that absolutely everything was tried to save his life. And sometimes that's the win that you get. And it's really, I mean, it's really hard sometimes. You know, you see these people and you think they're only 40, they've got, you know, all of this life ahead of them. And then we just can't fix it. And that's heartbreaking for all of us. But I also think, you know, you look at the silver lining that this family was comforted that they had tried everything and that this patient was able to be an organ donor and other lives were saved. And that's the best you can do, right, in a situation like that. Next slide. So then we have a 61-year-old Caucasian male with witnessed onset of right hemiparesis and aphasia. Witnessed onset, very important. Arrived to the ED within 40 minutes of symptom onset. Activase was given 33 minutes after arrival. A CTA revealed an M1 occlusion with a significant mismatch. And I get this question a lot, and especially from my cardiology colleagues. They're always asking me, oh, by the way, the trauma docs ask me this all the time. What does that mean? You're always talking about this mismatch. So let me tell you what that means. Basically, when we do perfusion imaging, what we want to see is a very small area of infarct volume, and it does show up. It shows up on our imaging as pink versus the penumbra, which shows up as green. So the greater the mismatch, the better. When the ischemia and the penumbra are closely matched, there's nothing to salvage. So when you think about mismatch, or you hear us talk about that, I want you to think about, you know, bigger's better here. The bigger the mismatch, the better for the patient. So that is one of the things that we look for, and that always makes us very pleased when we see that kind of imaging. We took that patient to IR where he had spontaneous resolution of his symptoms prior to the angiogram. They determined that they would just sit tight, abort the thrombectomy, but the patient returned to the ED and then the symptoms recrudesced, and we do see that. Sometimes there's just enough flow, heads down, you know, there's enough flow, and then that occlusion just fully occludes, and then they recrudesce their symptoms. So they were taken back to IR where the thrombectomy was successfully performed. He did have return of his right lower extremity strength, but remained a little bit weak on the upper extremity and had some aphasia. I can tell you that with good, solid therapies, this patient has now done very well and is able to speak and walk and drive and do all the things. So even though we may not see it initially, a lot of tools in our toolbox help us to help these patients recover. Next case. This is one of my particular favorites. This is a 13-year-old who presented to the pediatric emergency department with left-sided weakness and slurred speech and a mild right gaze preference. You'll see this a lot in large vessel occlusions. And when you see a gaze that's away from the side that is affected. So if you have left-sided weakness and you have a right gaze, that's pretty much going to be a large vessel occlusion until we prove it's not. We will rarely, but on occasion, see that with hemorrhagic stroke as well. So the minute we see that presentation, we're going to do all the things for this patient. Stroke alert was initiated. Patient was taken in for CT, CTA, CTP, and an M1 occlusion was discovered. TPA was initiated. Patient was taken for thrombectomy, which was successful. The patient recovered essentially on the IR table and was discharged 48 hours after admission and treatment with no recurrence. Obviously, pediatric neurology took over after we were all done with our fun stuff, looking for any reason that a normal, healthy 13-year-old would have a large vessel occlusion. None was found. And so this fell under this category that we call cryptogenic. I call it GOK. God only knows, and he's not telling us. Have no idea what caused this. This kid had, and the freaky thing about this kid He happened to be home from school. There was like, I don't know why, there was a day off from school. His mom happened to be home, not at work that day. And his dog was having puppies when all of this started. And I teased this kid. I said, listen, I'm pretty sure you need to name one of those puppies Terry after all. And he looked at me and goes, yeah, I don't think so. Like, oh, I tried. All right. But yeah, again, our young people, they will have these events and then go on to live healthy, normal lives and never have another one. And we don't know why. So this is an interesting subset of patients. Next slide. This is a 51-year-old Caucasian male who presented to an outlying hospital with severe left neglect. I don't know if you guys are familiar with what a neglect is, but I'm going to describe it to you. It's essentially like right down the middle of your body, you suddenly are completely unaware of one side of your body and one side of your world. And these are the people that even if you hold up that affected hand right in front of their face, they don't recognize it as theirs. We call that kind of an alien hand syndrome. The neglect is so profound, they have no idea that their own body parts are theirs. In a severe neglect, you can even see the patient kind of turning away from that part of their world and their body. It's very, very concerning syndrome because this is very difficult to recover from. And so trying to treat these patients aggressively is super important. So he was flaccid on his left side. He had slurred speech, which was nearly unintelligible. Only known history was type 1 diabetes, which is a significant risk factor. Upon arrival to the outlying hospital, he was noted to have an NIH stroke scale score of 19. So for those of you not familiar with the NIH stroke scale score, this is a score we use specifically for stroke patients. 0 is the score you want to have because that means you don't have any definable deficits. And the higher you go on that scale, the more significant and problematic that stroke is going to be. And that scale goes all the way to 42 points. But I promise you that if you're hitting 30s, you're probably not walking out of this hospital well, unless we can do something really aggressive to reverse this quickly. In this patient's case, last known well was in the prior evening, but unclear exactly what time. The non-contrast head CT was reported as negative for hemorrhage. And I like to spend just a little tiny bit of time on that. We get the non-contrast head CT on every single patient, not because we're looking for ischemia. The non-con will not very frequently not show us any ischemia. We are looking to rule out hemorrhage. And so that's essential. So we always get that first. And that non-con is very sensitive to bleeding. So that's why we do that first. The outlying hospital decided to proceed with a CTA, but we had no report back at the time of transfer. On arrival, the patient was reevaluated. The NIH stroke scale score at this time was 20. All of our scans were repeated. Oftentimes, if we have a patient transferring in, if those scans are an hour or more old, we will go ahead and repeat them because ischemia continues on. The longer the time, the more likely they are to becoming more and more ischemic. So we reevaluated everything. The CTA then at that point revealed an occlusive thrombus in the right ICA terminus that extended into the right M1 segment of the middle cerebral artery. The CTP revealed a very large core infarct. So at this point, what are our treatment options, would you think? Unfortunately, not many. Remember when I said that whole thing about mismatch? We look at core infarct. Now, there is data that's kind of starting to come around now, some early studies that suggest that there might be some value in attempting thrombectomy even with these large core strokes. But the risk of opening that blood vessel, very much like the cardiac patient, when you open those blood vessels, right, you can get reperfusion injury. Same thing happens in the brain. If you open that vessel, now you've got some dead tissue there and a fair amount of it. And the likelihood causing hemorrhagic transformation and significant hemorrhagic transformation kind of changes that risk benefit, and your risk becomes a little higher than your benefit. So that's why we kind of really make those decisions the way that we do. And I'll have you go ahead and change slides. We have a 40-year-old Caucasian male that was presented to the ED via EMS with sudden onset left-sided weakness, facial droop, and speech difficulties. Was here out of state for a work meeting, and according to a friend who was with the patient, he had been cracking his neck when symptoms occurred. Let me tell you about cracking necks and my crabbiness about that. It's very, very bad. Protect your necks, people. Don't you want to crack your other bones in life? Have at it. But if you crack your neck, you're risking a lot, and we'll go through this. This guy doesn't have any other medical history, no tobacco or street drugs, which, by the way, is a huge risk. I think we underestimate how incredibly damaging methamphetamine is. And we see so much of it, and I know you guys do too. It affects the vascular system, it affects the heart, it affects the brain, it affects everything. It's very bad. So we're very stringent about testing these folks. This patient was in an ED approximately 40 minutes after onset. His CT was negative for hemorrhage. His symptoms continued to progress. T&K was given, CTA, CTP completed, and at this time, the patient began to have difficulty with secretion management, and his speech was rapidly worsening. We had to intubate this patient for airway protection, and his CTA revealed bilateral vertebral dissections with early brainstem infarct and edema. It's not good. This is what happens to your blood vessels. The most at-risk blood vessels, when you think about cracking your neck, when you think about chiropractic care with high velocity manipulation, is those enteral linings of those blood vessels tear, and they either created their own occlusion, or they create a shelf for clot to form. And then those clots go up, and then they form occlusions higher up in the brain. So this is very, very dangerous. In this case, because they were bilateral dissections, rather than something we could go up and pull clot out of, and we already had early brain injury, the determination was made that we were not going to intervene. He'd already gotten the tenecta place, and so that was our best opportunity for him. He did eventually manage to be extubated, and he did go to acute rehabilitation. So it was a tough row for him and for his family. They were from way out of state, like Colorado or something. So it was a real challenge for them. Like I said, I can show you all the best outcomes in the world, but that's not reality, right? Not every STEMI survives. Nobody gets 100%. But I think it's important that we understand what patients do well and what patients maybe don't do well. So you have to look at both, right? So go ahead and switch, and we'll go to our 7th case presentation. We have a 71-year-old Caucasian male that arrived to Methodist via EMS, and was called as a trauma alert after being found down at home by family. Was poorly responsive, not moving any extremities. A CTA, CTP was completed. A left M1 occlusion was identified, along with numerous cervical spine fractures and a PE in the left lung. Was transferred to MercyOne for potential thrombectomy. Patient was intubated prior to transfer, so taken immediately to IR for thrombectomy, which was successful. However, the C-spine fractures were such that the patient was going to be quadriplegic, and there was no good assessment of higher level function. The family chose comfort cares, and the patient was deceased. So sometimes we win the battle and we lose the war. And this was a case where, we had a successful thrombectomy, but the patient's overall status was not going to be good, and family chose another route. So, and again, we supported that completely. That was a good decision on their part. And then next slide, And I think we're at discussion time, I think. So basically, what I want you guys to remember is that early and rapid recognition of stroke symptoms is essential to early treatment. EMS, early activation from the field, yields improved door to treatment times. We tell our EMS and we tell everybody out there in the world, we say this all the time, overcalls are going to happen. If we're not overcalling, we're undercalling, and that is a bad deal. Patients don't read medical books. They may not always present in classic fashion, especially in the posterior circulation. We get a lot of the weak and dizzies. And it's really, really important to understand what the story was, right? Because there's about 1 million things that can cause weak and dizzies. We need to understand what the story was. What was the patient doing at the time that this occurred? Working our way through it. We have to always think about the thing that can maim or kill your patient. I don't care if we have to overimage. I would rather do that and not miss that one stroke than unfortunately miss it. And then this patient's really got, to their detriment. So we try to be very, very aggressive here, which is, I think, the reason that we have such a successful program. And I'm very proud of it. But remember that despite technical success of thrombectomy and thrombolysis, not all patients are going to respond with clinical recovery. In my perfect world, one day they will. I'm going to wave my magic wand and they'll all be fabulous. But overall, so our success rate with our thrombectomy patients is over 88%. And that's one of the best in the country. And when you look at like just even door to puncture times, when we think about that time frame again, our typical door to puncture time is somewhere around 68 minutes. The national average is 90. So we do a really, really good job here. And we have a stroke village. I mean, there is no one person that does all of this. It takes literally a village. It takes EMS and all the ER nurses and docs and the CT techs and, the MRI people and our IR team and our neurology team. It takes all of us, our therapists, our social workers. When you start to put all those people together to think about all of those people that are required to take care of that one patient, it's really humbling. And I sometimes will remind patients of that, hey, I want you to know how big this team was that took care of you and got you to where you're able to go home again and be well. Because it's important for them to understand that from soup to nuts, people are working for them. And they should be very, very happy that we exist in the universe. So I don't hesitate to remind people of that every now and again. We will always do what's in the best interest of our patient. Sometimes that is standing down and not intervening when there is no hope for recovery. And again, I will end like I started, time is brain. Any questions that y'all have, I'm happy to try to answer.
Terri, this was great. I learned something every time I listen to you. I have a question for, I think we probably have many people on there that are in that public health space and not a clinician. So, a couple of questions, not on the clinical side, but, when someone says, oh, they had like a mini stroke, like, what does that even mean? And how do you treat those patients differently, or is it even clinically different, or do people just throwing it around?
So thank you. That's a great question. So people like to call these mini strokes TIAs. You'll hear that terminology too, right? That stands for transient ischemic attack. And basically that just means the patients had these symptoms that look like stroke, but they rapidly resolve, right? What we've learned as we've advanced in the imaging world, when these people come in, or if you see this or hear this in the public space, those patients should still be evaluated. We oftentimes will see evidence, radiologic evidence, that they've actually had a small stroke, but the symptoms resolved quickly. Either way, they should still be evaluated, looking for causes. And then we need to think about, what do we do to try to do secondary prevention of a bigger stroke? These are the patients that you're gonna look for the causes first, right? So maybe they have paroxysmal atrial fibrillation. They don't know that. Maybe they have, a number of cardiac things that can cause stroke. Maybe they have hypertension. They don't go to the doctor, so they don't know that. They've never had a cholesterol panel drawn. Maybe they're diabetic and don't know that. There's a million things, right? They're smokers. They have a lot of risk factors that they may or may not be aware of. They may be aware of them and they just look at you and tell you, well, and so you have to really try to identify those people. If you come across them, ask them, have you seen your doctor? Did you go in and see anybody about this? Did you go to the hospital? What did you do? Because especially these frequent mini strokes, as they like to call them, we call them harbingers of a stroke waiting to happen, a bigger stroke. And so by early identifying those patients and getting secondary prevention measures, such as starting them on an aspirin, starting them on some cholesterol reducing medication, all of those types of things really are going to help that patient to reduce their risk of having a full-blown stroke. So transient really means it was very short in duration, and it really doesn't show any signs radiologically of having caused actual ischemia. And so those are the things that we look at now, but that's what they're talking about when they talk about that.
Caitlin, I don't know if there's other questions in there. I have one more at least, as long as Terri has time for one more.
Sure.
So when you talk about like all the imaging, obviously that's happening here, but when we think about Iowa as a rural state, so when these patients present at their local hospital, what typically imaging and testing is available at those sites? And then how do you, like you said, sometimes you'll get stuff and it'll be an hour prior, but are our local hospitals equipped with what they need to assess patients before they send them to you?
So all of the hospitals in rural Iowa do have at least a CT scanner, which means they can do the non-contrast head CT, and we can at least rule in or rule out a hemorrhage. Many of them can do a CT angiogram and look for that vessel occlusion. Not all of them can. Almost none of them have perfusion capacity. So that patient that's going to require that level of imaging really needs to be at a stroke center like ours. Not even all of the stroke centers have perfusion capacity. I would say probably half of the stroke centers in the state of Iowa have it. It's very expensive. And I think a lot of these smaller hospitals in particular don't have the expertise to utilize it, don't have the funds to purchase it, and wouldn't know what to do with it if they did. So it really doesn't make sense for them to have that. The key piece that we need from them is that non-contrast head CT and the story. And then that determines whether or not they're going to get transferred here.
Caitlin, do you have other questions too? I mean, I could talk to Terri all day about questions I have.
Yeah, I guess one that I was kind of thinking of, I had no idea that cracking your neck was something that could be as detrimental as it is. Do you have any other general pieces of advice that people should take to take care of themselves from a stroke, whether it be like reducing risk factors or just having general knowledge?
Yeah, I think you nailed it. If you recognize what your risk factors are, then it's kind of incumbent upon you to try to work on those, right? If you have high blood pressure, golly, work with your doctor to get that blood pressure under control. I hear a lot of people, and I'm sure you guys do too, that are like, listen, I hate taking medication. I hate it. you're going to hate the stroke that you have a lot more. I can assure you. So, take your medication, know your numbers, know what your cholesterol is, know what your blood sugars are, know what your blood pressure is. I think one of the things that we can teach people out there in the community is how to check their pulse and feel it for regularity, right? If they're feeling those symptoms, have them go to the doctor and see if they've got it. They need an EKG. See if they're in paroxysmal AFib. A lot of times that just doesn't present itself in a way that patients are really aware of, and sometimes they have to actually be cognizant of it. So those are things that they can do. If you're a smoker, don't just say no. Meth, never say yes, period, or any street drugs, honestly. And I know that that's easier said than done. We live in a state that we know has a problem with that. But one patient at a time, one person at a time, we can educate, right? We can talk to people about getting help with that and stopping those bad habits. Do you know that, once you stop smoking between 5 and 7 years, you really do reverse a lot of the vascular damage that you do with smoking. And so it's important to recognize that it's never too late to try to be healthier and better.
Absolutely. Well, I will tell you, Terry, I was with the EMS directors yesterday, and it did not shock me that your name came up. So we're just so thankful for your leadership and your vision. And all Iowans are incredibly lucky that we have a Terri Hamm in our state, because I know you're super proud, but man, we're proud of the work that you guys do.
Well, thank you so much. And thank you for giving me the opportunity to talk to all of you today, because this is my heart, and watching. I don't know if any of you got to see the KCCI story with Laura Terrell and her husband. I think that brings the human face to the work that we do and how vitally important it is, because these are real people with real families and kids, and I don't know why I would ever want to do anything else. If we can just help these folks do better and go live happy normal lives, then that makes every day that we step in this door worth it to me.
Absolutely. Well, thank you so much for everyone for joining. I'm going to end this here. Thank you.
Thank you, guys. Bye.
Thanks, Terry. Take care.
You too. Bye-bye.
Bye.